My name is Mackenzie Taggart, and for my final presentation, I chose to highlight medication reconciliation errors during transitions of care. Why is this an important topic? Important clinical information can be lost as the patient transitions from one setting to another or from one provider to another. Adverse events are a common cause of morbidity and mortality, with medication discrepancies across care transitions are very common and can lead to morbidity and or mortality. Care transitions in the hospital are associated with a high risk of inadvertent med discontinuation. Errors of admission can lead to the increased risk of adverse events such as more ED visits, hospitalization, and even death. What is the purpose of medication reconciliation? Medication reconciliation processes can significantly lower the incidence of medication errors that can arise from an inaccurate medication history. A pharmacist's activity can reduce unnecessary hospital stays and readmissions due to the side effects of medications by actively monitoring potential side effects of prescribed meds during hospitalizations. Avoiding patient readmissions can help lower healthcare costs because the patient is not being readmitted for the same issue multiple times. For many patients, there are 4 times minimum that you should do the medication reconciliation. The first one starts with pre-admission. This goes for patients that are usually outpatient medications, and these are their active medications prior to the admission. You go through this along with their health history, noting what the medications are taken for and how often they're taken, and you properly put those into your charting system. The next time is at admission. These should be similar to the pre-admission medications, although it is including all medications, whether they are changed, unchanged, or have been discontinued previously. That way the providers have an accurate picture of what all the patient has been taking that led them to this point. The third medication reconciliation should happen at discharge if the patient has not been changed to another unit prior to discharge. These again should be similar to the at admission medications, although any possible medications added during the hospital stay, noting any new issues, should also be added to this medication reconciliation. That way, if the patient were to be readmitted, we would be aware of what medications they were taking prior to leaving. The fourth medication reconciliation should happen after discharge, whether this is with their primary care or another physician that they're seeing. These again should be similar to at discharge medications, although they could be changed whether their primary care ordered something new or they were recommended to see a specialist that ordered a new medication, or any other physician that might have added something related to their prior hospital stay. These should be updated with their primary care so the primary care still has an accurate picture of what the patient is now dealing with. How do these medication errors happen? There are 2 ways that this could happen: intentional or unintentional. Intentional is where prescribers or any healthcare staff inadvertently alter, add, or omit medications that were prescribed prior to the hospitalization. Unintentional is discrepancies during transitions of care that can be influenced by several factors: communication breakdown, incomplete or inaccurate documentation of the patient's previous medical history, or patient understanding and adherence to the medication issues, or an issue in cognitive function. And the last one is also inadequate med reconciliation practice for the staff themselves. How often do medication errors occur? It is approximately 6.5 per 100 admissions, which might not seem like a lot to some people. However, 6.5 of those patients are receiving improper medication based on many factors. Nearly 50% of all medication errors occur when a medication is prescribed or ordered, whether that be the wrong dose, the wrong preparation, the wrong route, wrong rate. There's many ways that this can happen, and it takes proper medication reconciliation to make sure that we are notifying and seeing all of these errors. Nurses and pharmacists help identify 30 to 70% of med ordering errors. There are multiple types of medication errors. As stated in the previous slide, prescribing can be one of them based on the wrong dose, incorrect route, wrong rate, or a big one is if someone fails to document the allergies and the physician is unaware of that patient's allergy and prescribes them a medication that does have an allergy. This is why never omitting errors and making sure to follow all hospital protocols and rules is extremely important for patient safety. How can we prevent medication errors? The best way is to open our eyes and pay attention. Pay attention when you're doing the med rec, listen to your patient, and accurately get their health history, along with closely collaborating with your physicians, pharmacists, along with patients, making sure everyone is on the same page. That leads into open and effective communication, keeping that floor open for the patient to tell you anything and everything regarding their medications and their health histories. The last is to identify any issues and address them. If you see something on the med rec looks wrong, investigate a little further and see what is wrong with that. Talk to the patient, talk to the doctor, and really figure out that issue so that we can get it fixed for the patient. These are the references that I used for this presentation. Thank you so much for listening.